Come on. Sound. Come on. Why don't I have any sound? Come on. This is terrible.
did notice on the guided reading that I was looking at, a lot of you put the skin test as a diagnostic tool. It is not a diagnostic tool, right? It's a screening. So a positive skin test does not tell us that the person has TB. It means they need more testing. Oh, I just looked at this. Okay, yeah, so exactly, diagnostic or screening test for TB. I just
Okay.
put in the chat. That the skin test is a screening tool. Diagnostic tools are what?
Yeah, key card, please.
Check if that's right. Yeah. Yeah.
Yes, I really can unmute yourself and talk about this.
Chest X-ray, sputum culture. Yeah, maybe a CT, but probably an X-ray would be the next step.
that's really the best they can give you on. It's basic. It's like, what does that mean? How would you, remember in professional roles too, you did what was called Malou therapy, or the Malou environment. This is where that really comes into play, is are you creating that environment that is safe for these different personalities to get the help they need? Does that make sense for that concept, why we had an exemplar of the Malou? What is that environment? How is it different? A narcissist isn't going to go to group, and if they do, it's going to be all about them and nothing about the group. So that's that. I think there was also a case study we put in. Doing those things will help you to get through. And then the gender dysphoria, there was also an article placed there that's very well done. It's a little long, but if you get the gist of it, you understand you can answer questions about gender dysphoria. Again, whether you believe it or not, except it's not about what you feel about it, it's how does the person feel going through it, is the best way I can say it. Remember, you have end of life, and if you go back to the readings, you need to know the difference between palliative care and hospice care. We talked about it in class when I was there. What is an advanced directives? There's different types. Person's still in control till it's activated. Because you'll have a daughter come running in the room, I'm the power of attorney, and mom's sitting there alert and oriented. I'm like, great, you're worth 10 cents with a piece of paper. Get out of here. I want to hear what mom has to say. Symptoms, like, it's about comfort. Book was pretty cut and dry about that. Lung cancer is lung cancer. They're going to cut it out. You're going to go through chemo. We've talked about side effects. So don't be spending hours on lung cancer. There's probably 2 questions. And then we had COPD and COVID, which we were going to get to for your gas exchange. COVID's still an issue. I mean, I had to send emails today because we used to fit test, but it costs a semester almost $750 at our department or state school. And so for summer, we said we're not going to fit test anymore, but then that limit's floating. So now we got to reevaluate that because Baycare, our biggest thing, says you have to be fit tested to go to the ED. So I had to send out emails about that this week. So COVID's not going away, but the gas exchange is important to understand, especially as that disease advances and we're putting people in prone positions. You're not to ventilators yet, but you'll get there next semester. It'll build. It'll build when we talk about how that lung is going to look really bad. We're just kind of at it. There is nothing from the speakers on the test. There used to be in the old curriculum. There isn't in the new yet. What other questions? Because I don't want to just sit here and talk. To a lot of black screens. I want to know what's going on. I want to be fly on the wall at Lindsay's room.
I have a question. I don't know if you can, just verify. So, I think we went over it, but we didn't have, I don't know. So, you know the TV, it says 10 mm. So, ATI says 10 mm and higher is a positive. But then when the CDC says 15. So, I'm, confused on which one it is.
The standard is 5, 10, 15. I have no idea why ATI says 10, but we're not going to trip you up on the difference between ATI and CDC. When you get out there and practice thing, you'll just need to know which standard your facility follows, but my guess is they follow the CDC, not ATI.
Yeah, okay. Thank you so much.
Sure.
remember when ATI was produced, the CDC could have changed things.
That's true.
So that's the other thing about nursing textbooks I hate. They're 2 years old by the time they're the new edition. They were written 2 years ago. So it's hard in class to say, well, your book is wrong, but we cannot help the CDC changes, and that guides practice. We talked about that with screenings for the first test.
Mm-hmm.
You know, I've done an ATI review in the last month, and I'm like, oh, your review book is totally out the window, because when that was published, that was correct, but now it's this.
And we talked about that too with COVID, right? When we learn new information, we got to change our approach. So,
which is interesting because for my license renewal for the state of Florida, I had to have it done by April 30th. Of course, I probably did it about April 27th. The COVID information that was in there for my CE continuing education unit for my license is now not what the CDC is saying.
yeah, it changed quick.
And it is June. Because I went out to the CDC when I was putting stuff together, because I will always go back out to what's current, not textbooks, and I saved my stuff from my license knowing we were having this as an exemplar. I found that interesting. That even the Board of Nursing was giving me wrong information in April.
Oh, there's another question in the chat. So, the Living Will, does Living Will, DNR, and Healthcare Proxy all fall under Advanced Directive?
Yes. Because each state will call it its own thing. I come from Wisconsin. We didn't even use a healthcare proxy. Down in Florida, you have to be a healthcare proxy. So a living will is about as basic as it comes and should be the least one used, in my opinion, because you're not designating anybody in a true living will. You're just stating what you want if you can no longer speak for yourself. Where a true advance directive in most states, or you're designating a healthcare proxy or designating someone to specifically make your decisions when you can no longer make them for yourself. And that's the big differentiation between a living will and what I call an advance directive, because the advance directive is I am directing someone else to do for me when I can no longer speak for myself. And that's why it is so important to choose the right person. And I gave the example in the pre-recorded lecture that I've seen this too often. The patient in their right mind, I don't want to be ventilated, I don't want TPN, I don't want prolonging my life, and gives the authority to one daughter. And the daughter doesn't do a damn thing the mom wanted. She gets her intubated, she keeps her alive longer, and then there's arguments among the siblings, and that patient that clearly stated what they wanted was not followed. And that in healthcare can become an ethical dilemma. But that daughter has the right because the mother designated that person as the healthcare proxy. Does that make sense? Do you see the difference? And
the advanced directive too includes the healthcare proxy, that person you appoint, but it includes all those other things Dr. Lindmeyer was saying. So like, you know, what are the wishes? So
like mine is
healthcare proxy doesn't necessarily include what the person's wishes are. It just, you know, it designates a medical power of attorney or whatever. But it doesn't necessarily include the wishes, whereas the advanced directive is all of that.
And with the healthcare proxy, this is another ugly thing that happens a lot and gets abused, is that can be court appointed. So that person has absolutely no relationship to that patient and makes decisions on somebody they don't even know what they want.
My family always, I'm like everybody's healthcare proxy in my family, and they all joke they're just going to pull the plug because I hate pain tubes and intubation and all of that stuff. But it's important to have these conversations with
you guys. You're asked on your driver's license if you're an organ donor, and I think we talked about this in class 2 weeks ago. How can you talk to somebody else about what you want till you really sit down and talk to your own family and realize how hard these conversations are. But go ask your grandma, go ask your parents if you don't have it. And they say advance directives before the crisis. You don't want to be doing this. I shared with you, I've had mine since I was in my early 20s. I haven't changed my opinion. I'll do it to you, but you are not doing it to me. When it's my time, it's my time. I don't want it done. I don't want to live on machines, and that's my choice. I might get dialysis for a couple of weeks, but that's different. I can still have a quality of life and travel and do things. It's choice, but it's hard decisions, and it's harder when it's a crisis. That was a good question.
If, like, when we were in SIM and that patient started saying, like, I don't want CPR, we need to get a provider in there as quickly as possible to acknowledge that and get it in writing. Because if it's not in writing, you're going to be doing all of it. So when a patient is known, we need to escalate that.
Till it's in writing, you legally have to do everything till it's on. And it is okay to be in the chart then we'll get the advanced directive, but the provider can write for a DNR, DNI. Get it in that moment. And they can change it. That's the beauty of these. I feel this way today, maybe 10 years from now, I'll go, well, a little longer. I can change it tomorrow.
And some of these rules vary by state to state.
Yes, they do. It's a pain in the ass.
Quizzing you on that, but you need to know when you go to practice what your state rules are.
I actually, with my parents, I had them in 2 states because they were different. So when they had 2 houses, I had advanced directives in Florida and I'd had advanced directives in Wisconsin because they didn't travel from state to state, and they had very different meanings in the states, in each state. And that's something to know if you have parents that like to move around. They need them in each state they will reside in because they don't transfer from state to state. The only thing that'll transfer is like in my folder right here, I have what's called a durable, meaning my son gets the money too. Like, so that legally will go from state to state because that's my will. Does that make, like, that's the will. Like, that's totally different. And you don't have to pay for these. They're free. Don't let lawyers fool you. Quiet group.
I have a question about cystic fibrosis. I know it's kind of off topic, but
all topics are fair game.
So between the cystic fibrosis patients, the respiratory infection, I can't pronounce it. It's like B. Burkhardia sepsia. I don't know. It's in the book.
Yeah,
I can't pronounce it, but can only cystic fibrosis patients get that infection, or can someone without cystic fibrosis get it? Like, is that why 2 cystic fibrosis patients can't be together?
Right, and they could have slightly different strains or whatever, so that's why they stay the 6 feet apart.
So, like, I couldn't get that bacterial infection, but just the cystic fibrosis could?
I think you can, but you're not going to get the severity that the cystic, like, you have the ability to fight it if you don't have it, Lindsay. They don't.
Okay.
So you might, yeah, exactly, have it, but never manifest the symptoms the way a CF patient would.
Okay. I was just wondering.
Yeah. Take that to, like, RSV. I may get it, but I'm not under 2.
Yeah.
Does that make sense? Like, under 2, they're going to just fall apart and be croupy and stridor and all that other stuff. I might just have a little cough.
Gotcha. Okay. Thank you.
Although not with last year's strain of RSV.
Oh.
What else?
I could sing and dance, but I can dance, but I can't sing, and I'm not standing up even though I have a cute little dress on.
We use all those resources available to you guys too while you're studying, right? You have ATI, you've got case studies, you've got the guided reading questions, all of that stuff. Make use of that. Look at the modules.
Go into your ATI Med-Surg book and do a little Google search, because I think ATI does such a good job cutting stuff down and embedding the little videos. So even that's why in the modules it'll say go to your Med-Surg ATI, because you can just do CF, you can do COPD, and they might have a little video in there for you, and just a little, I don't know, more than one place to read it, I guess is a good way to look at it. Because I'll give you an example. Like last night I was working on, because it's next week, the celiac PowerPoint. And when you look at the exemplar in Iggy, it's like a page, like a box and a half. And I'm like, well, they need to know a little bit more about CF than that. So then I did go to the ATI, and then I went to the Cystic Fibrosis Foundation, the Celiac Foundation. That's the same thing with CF. When that was put together, go out to CF. So if there's an organization behind it, they can explain it also in layman's terms to help you understand it better, and then go to the deeper reading. That is a way to study, you guys, because that is at a lower level, and then you can get into the nitty-gritty of it, whether it's CF or celiac disease, because the textbook is coming from a very deep, which you need to get to, but it's kind of nice to read it in a layman's terms first, and then see what. The other thing I noticed with people, just talking to some of you, is really understanding the terms. What do the terms mean? What does it mean if it's indurated, if you're looking at a TB versus, does that make sense what I'm trying to say? I noticed that with stroke. It's like you got to know the terms to be able to pick the right answer.
Sir, if you have a question, you can go ahead.
You're muted. All right, I couldn't figure out how to unmute myself on my phone. So, you know, when someone is infected with tuberculosis, like say I worked in the hospital and I was exposed to it and somehow I got the infection and then the little granuloma forms, and then like 2 years down the road, I take a TB test, will that show up positive? And then if so, if I get a chest x-ray, like, does that granuloma just stay there indefinitely? Or, like, so, okay. Because I couldn't really find it. Okay, perfect.
And you can get granulomas from things other than TB too. But yeah.
Okay.
Yeah.
Okay, cool.
Eventually, years down the road, it will turn into almost like scar tissue, but you'll still see it on a chest x-ray.
Okay.
And that's why imaging is so important. It is what we call active or latent.
And a lot of times it's found incidentally too, right? Like you're doing a chest x-ray for something else. Like when I had a PE last year, I ended up CT scan and somehow I have granulomas. I'm like, what the heck? I don't smoke. Why do I have this? But like, they're there. I mean, I'm fine, whatever, but they're there.
Would that be cause for treatment? Like if they knew that the granuloma was from TB?
If you also were positive on the sputum culture or the nucleic acid test or something like that, and you never completed your treatment or you were positive, then yeah, right, the latent versus active, even latent folks that still need treatment.
Okay.
Mine wasn't TB, but
your immune system is shot, girlfriend.
Oh my God, I belong in a medical textbook, honestly. The problem is none of my statistical anomalies apply to playing the lottery, just like all the bad things. Anything else, you guys?
Yeah, I put an ATI test out already. It's in that I put out earlier. And it's not all inclusive, but, you know, seek to understand and ask the question why. Why is that the right answer? Why would I do that first? Why is this important? No. Oh, good question, Ash. All right, so for the patient, you guys can all see the chat? Okay, so a retainer. CO2 retainers Their brain loves CO2. Our drive to breathe is a low CO2. Their drive to breathe is a high CO2. So 88 is fine for them if they're chronic. That's their bath. They live in a great place. If they got to 86 but aren't symptomatic, what's their respiratory rate? What is the rest of the picture? They may not need BiPAP. You have to look at the whole picture. And here's where the ABGs are going to come in, not your oxygen sat. I don't care about the O2 sat, because anytime your oxygen is changing, you guys, in any of us, we have peripheral perfusion and central perfusion. So if we're losing oxygen, blood's going to shift. You're not going to get a true O2 sat anyway. That's just how I feel. And most hospitals, and I love the last one I left, we went away from oxygen saturations to CO2 testing, getting the gas right at the nose instead of what's floating. Does that make sense? You have to look at the patient. If the patient is going into respiratory failure, then they might need BiPAP. But that is going to be individual to that patient.
And never based off an O2 sat alone.
Ever. You have to look at the whole clinical picture, compare the trends, and then we're going to look at the ABGs. Because as long as the pH is normal and their acidotic state hasn't changed, I expect their CO2 to probably be well 52 anyway. It's not going to be this 60 to 80. So you have to look at the clinical picture differently than like me or as a post-op patient in an oxygen sat. Does that make sense? There is disease-based. And they're retaining, which is a chemical brain change. So I don't care what the stats really are. I want the ABGs. And then I want to see, are they in the acute phase? Is this their compensant? Okay, let me bring this forward. This makes more sense. This is why we like CO2. I like to know they're a CO2 retainer because we have their ABGs at baseline of retaining. So I can see where the CO2 usually hangs on a good day. But then if they get pneumonia or they're crashing, that's when you can see more thick pH, CO2's going higher. It lets you know they're off balance. Because if you just looked at their numbers, you'd be like, whoa. Does that make sense? You got to start looking at those trends. That was a good question. This is where it's higher level. Like, I could care less what an oxygen saturation says half the time.
And their hypoxia is what's driving them to breathe, right? In these COPDers, they do the opposite of what a healthy person does. So if we reverse their hypoxia all the way up to, make them 99%, or get their PaO2 really high, their drive to breathe is going to be non-existent.
And that's why in the state of Wisconsin, they no longer allow LPNs in acute care to adjust oxygen.
Oh, that's interesting.
Sentinel events, too many sentinel events. Yeah, you got to know your nurse practice act, man. If you're going to be traveling and what you're delegating, it's wild.
I was telling my sim group too, I worked in a facility where there was a patient on BiPAP and the tech took her off so that she could eat. And left the patient alone without the BiPAP on, and ended up intubated. It was not good. So we need to also communicate with all of our ancillaries.
I had a student, this was years ago, but they were on a critical care floor, cardiac floor, and the student had gone to lunch, scheduled, perfect. Her nurse knew the whole bit, her aide knew. So did the right thing. She comes back from lunch and wants to see her 3 assigned patients. She walked in the room, and the patient is what we call a pundit, and it was the CO2 retainer patient. It's just like this.
Oh, God.
And you know the 60-second scan you think we're all to do in the room? Well, we drilled that into our students. Like, when you walk in the room, you better be looking at the same thing every time to catch the IV, the O2, where's the table, the patient safety. You guys know what the 60-second scan is. And going through the scan, she was right to that wall O2 thing, and it was at 4 liters. Patient should have never been over 1. She immediately turned it down, called a rapid. Had she not walked in the room, they said that patient would have died. And it was the aide that turned it up because the patient was short of breath coming back from the bathroom. And some PCTs and aides think they know. You don't need to know about your Nurse Practice Act, but you can go to Florida Board of Nursing and get the Nurse Practice Act.
And if you join your state board of nursing, which I would really encourage all of you to do, right, like become a member of the organization, they'll send you emails with all those updates, all those practice updates. And you also then have a voice when it comes to some of these laws and rules that are changing. You can go to meetings, you can advocate for nurses, you can do all those types of things. But I still get emails from Maine, from Pennsylvania, from Tennessee, from Colorado, now from Florida, but they'll update you. I mean, ultimately, you're responsible for it, but joining, being an active member in the board or the state nursing committee is a good way to stay abreast.
Yep. And it's a great way to stay. And that's the thing, you know, those people that travel, you better stay on top of the stuff because they will sue you.
Mm-hmm. Yeah,
they can come right after you because you're practicing in that state. And like a different thing is like in the state of, I think it's a school rule. I don't know if it's a school rule or a state rule, but you guys can't push IV meds. My students were doing art lines and pushing meds and doing things. So when I got down here to teach, we were teaching IV push, and I go, yeah, when we go to clinical, and the other instructor's like, what the hell are you talking about? They can't do that. I'm like, can you let me know what a student can do in the state of Florida? Because I was going off what I'd done for 20 years prior to coming down. So even as instructors, we have to know what a student can do and not do. My students were allowed to do anything but blood products.
Yeah, same.
They could do platelets, fresh frozen plasma. They just, for whatever, because it's not a type
they
of
couldn't do PRBCs, yeah.
Yeah, that's the only thing they couldn't do. So we're just like you guys. When we're new here, we got to check what the delegation is. I got to know if you're in clinical and what's going on.
And as an NP too, it varies significantly state to state.
Mm-hmm.
Turnover, please.
Don't overthink it, but remember, it's gas exchange problems causes COPD. The treatment may be a little different. It's gas exchange and cystic fibrosis. What is different? That is their lungs and their GI system. Oh, it's COVID. I'm more worried right now, and I think I shared that. I probably didn't, but there's a great CDC thing on long-term COVID that's brand new from last month. 2 months ago. And what we're looking at now, it's not so much about COVID transmission, we get that, but now what are we seeing with what they're calling long-term COVID? And my friend was just hospitalized. He had COVID. He was an old smoker, quit smoking, got COVID, did very bad, hospitalized, BiPAP, the whole bit, and just developed pneumonia a couple weeks ago. And he has, since this pneumonia, he looks like he has COPD almost end stage. He can barely walk. He needs inhalers. And they said it wasn't from his smoking because they had already known what his lungs look like. It is the effect of the COVID that scarred his lungs that now make him look like a COPDer. But it's still a gas exchange problem. Bronchodilators are always first. Steroids when needed. Like, that's how you add those gains in. There's only 5 major respiratory drugs. Then they're on antibiotics or virals or pancreolipase. But pancreolipase isn't for the lungs, it's for the gut to break down fat. Does that make sense, you guys? Like, it's still the same problem. It's gas exchange. It's what caused it. You must have done great on osteo. There's no questions.
I guess so.
It's all my content. I'm just kidding.
But also osteo, right? You got your acute, your chronic, you got broad spectrum, long-term antibiotics, could progress to surgery, all that good stuff. Wound care is essential. We got our indirect and direct methods of entry. Diagnosis through imaging or bone biopsy, right? I guess we're going to do great on the exam. This is awesome.
I think they are. That was an hour of off 4 questions and then a couple more in the chat room. Anybody else? Anything at all? If not, we'll call it a Friday morning. So you can, oh, it's going to rain this weekend. Stay dry, get outside amongst the raindrops. They said it's going to be sporadic. We need rain. That's all I got.
That's all I got. Thanks, guys. Have a good rest of your day and weekend.
Thank you.
Bye. That is so funny. My screen every now